Concerning the third part of my presentation, the patient's voice, in Portugal there are more than 20 patient organizations that represent different diseases, as you can see here in this slide. And all these associations, they advocate for the development of policies in the rare disease area. In Europe, there is EURORDIS, the European Organization for Rare Diseases, that was founded in 1997. It has almost 500 members and represents more than 4,000 rare diseases. The mission of EURORDIS is to facilitate the participation of patients in patient groups and to federate these patient groups with the goal of achieving a more powerful unified voice. EURORDIS is present in different institutions and as well in different committees. For example, EURORDIS is present in the Committee for Orphan Medicinal Products at the European Medicine Agency. It is as well present in the European Medicine Agency Committee for Proprietary Medicinal Products Working Group with patient groups. EURORDIS is as well present in the Rare Disease Task Force at the Directorate General for Health and Consumer Protection, and it is as well present in the European Health Policy Forum at the DG Health and Consumer Protection, and finally it is present in the European high-level groups on health services and medicinal care. A part of EURORDIS, there are other consortiums for patient organizations with a role in the healthcare issues. In one hand, there is the European Patients Forum. On the other hand, there is the EPOC, the European Platform for Patient Organizations, Science and Industry. And finally, there are other two big organizations, the IACO, which is the International Alliance of Patient Organizations, and finally the European Forum for Good Clinical Practice. Other examples of patient involvement is at the level of the European Medicine Agency, in which different patient representatives belong to different committees. For example, there are patient representatives that are membership of the European Medicine Agency Management Board. Other patient representatives are present in 3 scientific committees, the COMP, the Committee of Orphan Medicinal Products, the PDCO, Pediatric Committee, and finally in the CAT, the Committee for Advanced Therapies. A part of these committees, patient advocates, they are as well present in the Patient and Consumers Working Group. They are as well present in the activities of the Committee of Proprietary Medicinal Products. They are as well present in the review of product information, the EPAR summary and package leaflet. And finally, they are members of the working group on clinical trials in third countries. And finally, there are patients that are acting as observers in the pharmacovigilance working party. In order to get patients involved in different committees and institutions, patients are becoming more professionalized. Patients are informed, they are able to interpret data, they are able as well to perform different reports about their own disease. And there are different activities undertaken by different organizations that give some training to patient representatives. In one hand, you can see here in this slide that the DIA, the Drug Information Association, has, for example, the Patient Advocacy Fellowship Program. There are as well conference scholarships opportunities in order to facilitate the participation of patient representatives in different conferences, such as in the genetic diseases of children. There are some scholarships for families in order to allow their attendance. And as well in the conference, in the International Conference for Orphan Medicines and Rare Diseases organized in Sevilla, in Spain, there are as well different scholarships. Finally, Rordis, they promote and organize the Rordis Summer School, and in this case they are as well fellowship for patient advocates, and this training program is focused on clinical trials and drug development. Finally, other training activities are, for example, the ones promoted by APPHARMA, the Associação Portuguesa da Indústria Farmacêutica. They give training focus on clinical trials. There are as well fellowships for patient representatives for the Health Technical Assessment Summer School, and there are as well possibilities for patient representatives to participate in a training in which that allows families or patient representatives to go to laboratories and to do practical training for 1 week in the École de l'ADN in Nîmes, France. Concerning the Portuguese Association for CDG and other rare metabolic diseases, our organization, in brief, you can observe in this slide that our organization was founded in 2010. It is a non-profit organization. We are in total 42 members. 2 are honorary members. One is Professor Jaken, the medical doctor that discovered the congenital disorders of glycosylation, and another one is Dr. Maria Antonia Vilaseca, one biochemist in Spain that worked for several years in CDG. We are covering 2 rare metabolic diseases right now. We are in total 6 volunteers. Some are in Portugal, Spain, United States of America, and Australia. The volunteers, they have different functions. They are volunteers that are focused on social and advocacy affairs. There is one volunteer that is focused on accessibility, another volunteer that is focused on scientific and management affairs. There is a website manager, and finally there is 2 volunteers that are more focused on translating the documents that we have available for our families. We are a Rordis member, and our annual budget is limited, and our funding resources are basically coming from the membership of our members. And we aim to build a global voice to fight against the impact of rare metabolic diseases in our families, and we aim to improve the quality of life of our families. In this slide you can find our working model. So in general, patients and families, they go to the medical doctor, they present a diverse clinical spectrum, and the medical doctor will apply to basic research in order to learn which diagnosis it is, and it will apply as well to clinical research in order to improve certain characteristics of the disease. When the medical doctor transmits the diagnosis to families, this is a critical moment to families, because in general it is difficult to understand the diagnosis, and different and complicated names started to appear, such as gene mutation, genetic counseling, gene therapy, etc. A part of the initial shock that families suffer, there is as well difficulties in order to understand the diagnosis. So one of the goals of our organization, it is to coordinate and organize all kinds of activities in order to improve and improve the knowledge about the diseases, and as well to inform families about their diagnosis. I would like as well to point out that the majority of rare metabolic diseases, they don't have a cure, and the prognosis in general is very, very bad. Hereby in this slide you can find the vision and mission of our organization. We aim to build a patient-centered research in order to improve care, and we aim as well to coordinate activities that link the four main stakeholders: basic researchers, medical doctors, clinical researchers, and families. So we are undertaking different activities. On one hand, we support families by informing and empowering families. On the other hand, we are promoting activities in order to boost networking, to boost as well awareness and education. And we are as well potentiating activities at the level of scientific and medical research. And finally, the different activities that we promote, they will give as a final result, or we hope that will give as a final result, the development of treatments and orphan drugs. And finally, we hope to improve and potentiate advocacy of rare diseases as a public health issue. And we hope as well to advocate to the improvement of policies in the rare disease domain. Just to finish the presentation of our organization, I would like to point out that we have a medical and scientific panel that is related, that work in different areas, such as gene expression regulation, stem cells, cellular and neurobiology, regulation of the translation control, development and growth control, and neurodevelopment. And our organization, it is representing all rare metabolic diseases in which there is not an association already established. And currently we are focused on congenital disorders of glycosylation because we have the majority of our members, they are affected by these rare metabolic diseases. So concerning congenital disorders of glycosylation, this is a booming disease of sugars. You can observe in this slide that once the protein is translated, the protein suffers different post-translational modifications. It can be phosphorylated, acylated, ubiquitinated, or glycosylated. Glycosylation is one of the most important post-translational modifications that happen in proteins, and it is very important for the functionality of the proteins. The glycosylation has different functions, as you can see in this slide. In one hand, it can be glycoproteins, they can be transport proteins such as transferrin. Glycoprotein have as well a structural function, like for example collagens. It has as well immunologic functions. It has as well cell attachment recognition site functions. And finally, it is very important for the regulation of development, for the hemostasis and thrombosis. There are many hormones that are glycoproteins, and finally glycosylation can affect, it is important for protein folding, and finally as well for the interaction with specific carbohydrates. The congenital disorders of glycosylation, it is due to deficiency, and the congenital disorders of glycosylation, it is due to an impairment in glycosylation. In the upper part of this slide, you can see one glycoprotein correctly formed. In green, it is the protein, and the different antennas, they are the glycans, the sugars. And in the upper part, in the parte de baixo, below, lower. Yeah. Yes.
Não as mãos.
Levanta as mãos?
Não ponha as mãos para baixo. Lembra-se disto que eu lhe disse, ficar assim com as mãos escondidas.
So, congenital disorders of glycosylation are produced or are due to an impairment in glycosylation. In the upper part of the slide, you can see glycoprotein correctly formed, in which in green it is the protein and the two antennas are the glycans or sugars. And in the lower part of this slide, you can see glycoprotein can be incorrectly formed. In one hand, we have glycans that are missing, as you can see in this part of the slide. And when glycans are missing, we classified congenital disorders of glycosylation like type 1. And on the other hand, glycans can be not correctly formed, and in this case it is classified as CDG, Congenital Disorders of Glycosylation type 2. The diagnosis of rare diseases, and in particular of congenital disorders of glycosylation, it is an important area of concern. CDG at the neurological level in general presents a global developmental delay, and it has a very diverse clinical spectrum. This obliges families to see different specialists, to do several medical exams, and sometimes there are delays in diagnosis. Furthermore, the global developmental delay can be due to different causes, like for example infection, trauma, exposure to toxins, uncontrolled seizures, etc. This means that many CDGs, they might be misdiagnoses. And for families, it is important to have a correct diagnosis, because without diagnosis, patients and families cannot access to effective treatments, therapies, or it is difficult as well to manage the disease without the diagnosis, because families will not have access to a proper social service. Fortunately, nowadays CDG is taking advantage of the development of different techniques, such as screening techniques like the transferrin isoelectric focusing, the capillary zone electrophoresis, the high pressure liquid chromatography. And there are as well techniques for further investigation of CDGs, like for example the lipid-linked oligosaccharides. This is to diagnose the CDG type 1. There are as well the techniques for apopolyprotein C3 that allows the diagnosis for CDG type 2. And there is as well the possibility to do a glycan analysis via mass spectrometry or MALDI-TOF. And finally, the confirmation of CDG diagnosis, it is done by the measurement of enzymatic deficiency, and as well for researchers will look for genetic mutations, and nowadays exome sequencing, it is being applied to CDG. All these advances in technology allows to families to receive the diagnosis much earlier and faster. I would like to point out that until 2009, CDG was classified like CDG 1A, 1B, etc., or CDG 2A, 2B, etc. But since 2010, due to the new CDG discovered, there was a need to modify this nomenclature, and nowadays CDG, they are classified like PMM2 CDG, which is the name of the gene, and followed by CDG, and sometimes people use in brackets the old name of the disease. As you can appreciate in this graphic, lately new CDGs, they are being discovered, and nowadays we know 16 defects in N-glycosylation. We know 7 defects in protein O glycosylation. We know 3 defects in lipid glycosylation, and finally we know 17 defects in multiple glycosylation pathways and other pathways. Concerning the clinical spectrum, CDG, it is a multisystemic disease, and any organ can be affected. At the neurological level, patients, they can present ataxia, muscular hypotonia, microcephaly, stroke-like episodes, cerebral atrophy, epilepsy, abnormal eye movements, and many times it is very often that patients, they have a psychomotor retardation. At the level of heart, patients, they can present pericardial effusion, hydrops fetalis, or cardiomyopathies. At the renal level, patients, they can present congenital nephrotic syndrome. At the level of skin, patients they can present inverted nipples, abnormal fat pads or ichthyosis. And at the level of eyes, patients they can present retinitis pigmentosa, optical atrophy, or strabismus or coloboma. Finally, at the level of coagulation, there are sometimes parameters that are modified. For example, patients they can present a decreased level of protein C, they can present thrombosis, bleeding tendency, they can present a decrease in clotting factor 11 activity, and finally they can present a decreased antithrobin 3 parameter. At the level of laboratory, sometimes patients they can present anemia, leukocytosis, Bombay blood group, they can present a high level of liver enzymes, a decreased levels of cholesterol and cholinesterase, and at the level of gastrointestinal, patients they can present, for example, in the CDG1B, they can present a chronic diarrhea. They can present as well cycling, vomiting, or hepatic fibrosis or protein losing enteropathy. At the level of skeletal and growth, patients they can present a delay in growth, they can present a growth retardation, they can present a hypogonadism, failure to thrive, or a joint contractures. As you can see, this is a very complicated clinical spectrum, and we should suspect about CDG anytime that we face an unexplained syndrome. Those congenital disorders of glycosylation, they are a challenge disease of sugars, and we have to take into account that 1 to 2% of our genes they are involved in glycosylation. This means that more CDG are still to be discovered. Concerning specific treatment, even if we know so far almost 50 different CDGs, only one CDG has a specific treatment available, which is the PM isomerase CDG or CDG1B, in which the treatment consists in simple daily oral mannose, which is an effective treatment for patients with this potential lethal disorder. On the other hand, there are partial treatments. For example, some patients with SL35C1 CDG or leukocyte adhesion deficiency type 2, they respond to simple supplementation of oral glucose, which alleviates some symptoms. And finally, for the PGM CDG that causes an histone hypoacetylation, butyrate increases PGM transcription, and its supplementation was able to control seizures in one reported patient. Concerning symptomatic treatments and preventive measures, there are patients that present failure to thrive, and sometimes it is needed to consider a nasogastric tube or a gastrostomy tube feeding. Other patients they can present strabismus, and they can be advised to use glasses or patching or even to perform a surgery. In the case of stroke-like episodes, low doses of aspirin might be very helpful. In the case of the oral motor dysfunction, it is sometimes patients they are advised to consultate a gastroenterologist or a nutritionist. In the case of osteopenia, that it might be present in CDG adults, for example, it is patients are advised to do treatment with bisphosphonate therapy in the case of severe forms. In the case of pericardial effusion, some patients they can be treated by corticosteroids and salicylic acid, or even they can perform a pericardial drainage. Finally, concerning scoliosis or kyphosis, sometimes there is a need of surgery. And finally, when there is a through hypothyroidism, the supplementation of L-tyrosine can be helpful.